after such a nice presentation given by Dr. Sham, I'll go ahead with the next topic, that is assessment and perioperative management of coronary artery disease patient. Posted for non-cardiac surgery. I'm getting an echo. Is that okay? Okay, right. So, so this has already been explained very well by Dr. Sham, and the implications of this are that the right coronary artery, whenever it is blocked, we have to look for bradyarrhythmias most importantly, because not only the inferior wall and the posterior wall, the right coronary artery also supplies the sinus sinoatrial node. And am I audible?
Yes, madam, audible, madam.
Madam, you are very audible and comfortable. I mean, it's very good. You can just go on.
Echo, actually. I'm hearing my
You are using both the earphone and the your laptop, so you'll get an echo. But we are comfortable.
Yeah, I request all others to mute their microphone, please.
Right. The right coronary artery, apart from the inferior wall, the posterior wall, also supplies the AV node and the SA node. That's why intraoperatively one has to look for bradyarrhythmias and maybe even heart block. So one has to be ready with that. And the left main coronary artery and its branches supply the walls of the heart and the interventricular septum. So one has to basically, I can't hear any of you. So I think I will still go ahead with the presentation. Right.
No,
and
madam,
the PDA supplies both the
what happened is we have all
which from it will supply the interventricular septum, and that will, in the major cases, in very bad cases, can also lead to ischemic VSD. So one has to look for that intraoperatively. So this is the implication of the supply, the right coronary artery and the left coronary artery. Now, my slides are not moving. Hello?
Yes, madam. Yes, madam. Tell me. Your slides are not moving.
Yeah. So, yeah, the slides were not moving. Now they are. So, in the presence of ischemic heart disease, when we post a patient for non-cardiac side, there is an increased risk of about 25% in comparison to the patient posted for a cardiac surgery or a normal surgery. So,
madam, sorry to interrupt you.
Implications.
Madam,
the operative complications.
Sorry to interrupt you. The slides are out of the screen slightly.
Yeah, my slides are not.
You have to adjust the slide also.
Or else, madam, you can just use this share screen option. Share screen option is the, you can share your screen with us.
Oh.
Now we can see only part of the slide.
Share screen option is on the bottom right icon, madam. Yesterday I have informed you, bottom right fourth icon.
Yeah, that option is not opening.
Okay. Yeah. Can you see the fourth option now? You are visible. You are able to see.
Yeah, I am able to see, but it's not opening.
You just have to minimize this height presentation.
Okay.
And you can just do the screen sharing with us.
This option is not opening. Okay.
Yeah. Madam, can you see now?
Yeah. Is it visible?
You can see your PPT even now. Actually, it's visible on a screen. Like, what are you trying to do now, madam? You are actually not. You are using the pen. You are trying to use the pen and do something on the PPT. Yeah, you are using the pen, madam. Just to come out of it, on the right side bottom, there is a share screen option is there. For beside the webcam button, beside the webcam option.
Yeah.
Yep, just press on it. Share screen. Beside the webcam.
Okay. This share screen option is not.
Ramakrishna.
Yes, yes, sir.
Let her present.
I opened it.
Let her present. You present it, madam. A very small part is going on. That's no problem. If you are able to do it, it's okay. Otherwise, we'll just continue with the presentation.
Yeah.
Yeah, you can continue, madam. We are comfortable.
Yeah, I tried to open that.
It's okay, madam.
I tried the webcam thing.
Yeah, right on the webcam.
Yeah, you can go ahead, Dr. Abhiruchi. I'm Dr. Satyanarayana. You can go ahead. Whatever, it's not a problem. A small thing is.
Abhiruchi, you can see. Yeah. You can carry on, madam.
Okay, so in the presence 35%, and the operative intraoperative complications like myocardial ischemia, cardiac failure, arrhythmias, cardiac arrest, and this complication is much higher in patients who have decent MI or unstable angina, or in those who are requiring urgent or emergency surgery.
Net is, I think, breaking, sir. Madam's net is breaking, sir.
Which was done in 2020, which was published in 2020, but it was done over a period of around 25 years. And it says that the prevalence is on the rise, and by the year 2030, there will be about 1,845 IHD patients per 1 million population. So the prevalence is going to be on the high. And with the event of the COVID pandemic, because it is a prothrombotic do I continue?
Yes, madam. We can hear you. Please continue.
Right. So with the advent of the pandemic, because it is a prothrombotic pathology, the incidence and the prevalence of ischemic heart disease is even going to be more higher. So what the anesthetist is worried about is major adverse cardiovascular and cerebrovascular events, which we often refer to as MACE. So this is what one is wary of, especially in the perioperative period. What we look for is, or what we try to prevent is myocardial infarction or its complications in the form of dysrhythmias, hypotension, congestive heart failure, or acute mitral regurgitation, pericarditis, ventricular thrombus formation, or a complication of MI, as in VS rupture or any other cardiac death call, or maybe the stroke in the form of embolization, in the form of complications, brain or any other organ. So this is what the anesthetist is generally wary of in the perioperative period. MACE events very common. So there is a study which was done in 2017, and they proved that out of the 33 hospitalizations, one patient who was posted for non-cardiac surgery. For every 33 patients posted for non-cardiac surgery, one patient in the perioperative period had one MACE. So that is, it is very common. The prevalence is around 3%. And the prevalence is very higher in vascular surgeries, followed by thoracic and then transplant surgeries. So these non-cardiac surgeries, one has to be very careful while handling ischemic heart disease patients. So the problem is not very cannot be right. So I have to wait for every slide, so please excuse me. In the preoperative evaluation, one has to look for the risk factors that the patient presents with. Non-modifiable risk factors and modifiable risk factors. So addition of every risk factor increases the overall risk of the patient in the non-cardiac procedure. So the non-modifiable ones we cannot do anything about. The modifiable ones are raised or altered levels of blood cholesterol, raised triglycerides, high blood pressure, which can be controlled with drugs. These glycemic control can always be modified. Smoking, we can always ask the patient to stop smoking 4 to 6 months prior, so that the levels and the complications of airway reactivity, etc., are less. Overweight and obesity, these are modifiable to some extent, but what we can do is that if it is an obese patient, then we can always go for the stop bang questionnaire, and maybe a perioperative CPAP can help and reduce hypoxia or any other event of airway problem occurring in the perioperative period, which can, if occurs, which can lead to aggravation of the ischemic heart disease. Excessive alcohol can also be modified, and stress can be relieved with anxiety, anti-anxiety drugs. So the severity, progression, and functional limitation imposed by the ischemic heart disease has to be first evaluated. One has to take a detailed history of ischemic heart disease, when it occurred, the duration of the ischemic heart disease, how it progressed, whether hospitalization was required, whether the patient underwent any procedure for that, the medications that were the patient was subjected to at that time, and the current functional limitation that the patient is under, the number of activities he can do day to day. So this can be evaluated on history itself. You can ask the patient the activities that he does normally in his day, and dyspnea at rest or any other activity has to be evaluated. The exercise capacity. In the PAC clinic, you can ask him to do a 6-minute test if the patient is mobile enough, and the test for climbing stairs and evaluating his functional capacity can also be done. These evaluations determine the cardiac reserve of the patient. So long back, the Canadian Cardiovascular Society has given us the classification of angina. So on history, this can also be evaluated. That the patient has had chest pain at very low physical activity. If the patient gives a history of class 4 angina, then the risk is much higher than the lower classes. So after taking a history of the functional limitation of the patient, one has to place him in the risk assessment. So if the patient can do active strenuous exercises and is walking and has no other functional problem, then you can be very rest assured that the perioperative period is going to be more or less smooth. But 4 to 10 METs when the patient exhibits. METs are metabolic equivalents, and 1 MET is equal to about the oxygen consumption of about 35 milliliters per minute. And when the patient exhibits exhaustion or dyspnea 4 to 10 METs on moderate exercise, then the risk of developing a perioperative increases. And when it is less than 4, then definitely the patient has a very high risk of developing a MACE in the perioperative period. So in history, we need to know the detailed history of all the cardiac events, all the cardiac procedures and hospitalization. The most recent investigation, especially the 2D echo of the patient, will give you an estimate of how the heart is functioning. So that will give you the amount of damage that has already been done by the ischemic heart disease, and will also give you an idea of what all procedures has been done, position of the stent if it has been placed earlier, or if the patient has had a graft with the help of a CABG, and how the graft is functioning. All these details can be assessed with the help of a 2D echo, which is the more recent, better. Coronary angiogram or a 2D echo is mandatory. Then you need to know the detailed history of all the implants, the type of implant, when it was inserted, and the drugs the patient is on. If the patient has received implant, then he is likely to be on dual antiplatelet drugs. So the nature of the drugs and the duration of the drugs has to be taken down. The history pertaining to congestive cardiac failure, whether the patient has at any point of time landed up in CCF or any arrhythmias or has had any syncope, this history has also to be taken down. This is very important in order to see whether the patient develops any perioperative MACE. Other systems, depending upon the type of non-cardiac surgery, we are anyways going to take the history depending upon what surgery the patient is posted for. But in respiratory system, if the patient has cough, then this may one may not be of pulmonary origin. One has to remember patients with ischemic heart disease may also complain of orthopnea and paroxysmal nocturnal dyspnea. So this can also be of cardiac origin. One has to be very vigilant in seeing whether the patient has any components of right ventricular failure for that matter. A long history of cigarette smoking can also have COPD. Diabetes, the patient has to, if the patient has diabetes, then the complete drug history has to be taken, and any history of his hospitalization, any events related to diabetes mellitus, and recent investigations, including hemoglobin, all this history has to be taken. Similarly, hypertension history has to be recorded. Generally, with IHT, these two go hand in hand. Most of the patients do end up having diabetes and hypertension. So these three things generally go hand in hand. There is there are many studies which say that probably because of geopathy related to diabetes, because of cells depositing inside endothelium of the vessels, there is dyslipidemia, and that is maybe atherogenic, which might lead to ischemic heart disease. So what leads to what is still a subject of research, but diabetes and hypertension and ischemic very commonly linked. So very careful with the diabetes and hypertension and ischemic heart disease. So on CVS examination, apart from the other systems, CVS examination has to be done in the patient. And if you put the stethoscope on the carotids, if you hear a bruit, then that may indicate that the patient might land up perioperatively in a mix event. So there is no harm in just putting the stethoscope on the carotid and listening for a bruit. Assess orthostatic hypotension, attenuated autonomic nerve system activity, that would also indicate the events which you have to look for in the perioperative period, especially when you're using a lot of drugs which affect the sympathetic system. Then JVP and peripheral edema can give you a hint of right ventricular dysfunction. On auscultation, if you look for left ventricular dysfunction, signs of left ventricular S3 gallop and rails, then it is a good idea. So when the patient is posted for non-cardiac surgery and you know that he already has ischemic heart disease, you do a workup, and in the workup you have to do a 12 bleed ECG. This will give you details of the heart is damaged. Then cardiogram will always serve a purpose, even if the patient has a recent echocardiogram. If you do it in your institute, then when doing that, if the patient has any evidence of arrhythmia, then you can also go for Holter monitoring. And if the patient is mobile, then you can do exercise electrocardiography in the form of a treadmill test. But if the patient is, for instance, if the patient comes up for a fractured neck femur, post-operative surgery, then pharmacological stress testing can also be done on drugs. So this will give you an idea of. So in the investigations, some investigations are very important. You need to know the hemoglobin of the patient, because as Sham has already told you, the balance of supply, the supply side depend upon the hemoglobin saturation. surgery, the cutoff point of hemoglobin for non-cardiac surgery would be more than 8. But if the patient already has IHT, then it is always better to have a higher. If the patient has a HB of around 10 or so, then that should be fine. Coagulation profile is very important because the patient is likely to be on dual antiplatelet drugs. And this will help you in planning your renal function is also important. Why we'll be seeing in the risk assessment. So risk stratification has been long proposed, and it was proposed by Goldman in the earlier century. In 1970s. After that, it was modified several times. DESC by 1886. Then the most used disk stratification is given by Lee in 1999, and we still use it with a little modifications, and we call that the revised cardiac risk. Index. Now, why is the risk stratification important? It is important because perioperative, the risk of and the risk of posted. Even the ACC and the AHA guidelines in 2014 were modified, have given modified risk stratification indices, and they were still modified in 2017, and they included cardiac biomarkers, especially troponin 1 is MI cases. If the patient has a recent MI event just before surgery, then that also has to be included. But what we generally use is the RCRI index. And this is another index which was given recently. It is the National Surgical Quality Improvement Database, in which 5 factors: the type of surgery, the functional status of the patient, elevated creatinine, age, and the gender of the patient. The classification are important. So that brings us to the revised cardiac risk index, and every point has every factor has 1 point. So if the patient is posted for a high risk surgery, especially a suprainguinal vascular surgery or a thoracic surgery, or if the surgery is an emergency surgery, and this falls into high risk surgery, and you get 1 point. If the patient has recent history of ischemic heart disease, then that is another point. If the patient has had history of congestive heart failure, then that would be another point. History of stroke or cerebrovascular episode gets another point. If the patient is preoperatively placed with insulin, if the patient is diabetic and the requirement of insulin is there preoperatively, then that gives another 1 point. And if the creatinine is more than 2 milligrams per deciliter, then that gets another. So there are total 6 points, and high risk procedures, as I said, are suprainguinal vascular surgeries, emergency surgeries above 60 years of age, intraperitoneal surgeries, and intrathoracic surgeries. So any of these procedures get 1 point in the risk stratification method. So if there are no predictors, then the risk is around 0.4%. It is not nil, but it is 0.4%. And if there is one predictor, then the risk is just 0.9%. So with increase of every factor, the risk increases. With 2 predictors, it becomes 6.6%. With 3 or more than 3 predictors, it is more than 11%. And generally, all the IHD patients, as I said, are either diabetic, hypertensive, or do have sort of, um, uh, or if they are even posted for emergency surgery, 3 predictors. Very, very in risk assessment. More than 3 predictors, the risk of a perioperative MACE is more than 11%. So it is, one has to be very careful. So if the risk of perioperative MACE is very high, and the non-cardiac surgery is not very urgent, then you can maybe think of for revascularization. There are certain certain conditions in which you can go for elective revascularization. If the patient has a acceptable coronary revascularization risk, especially if there is a left main coronary stenosis, or if 3 vessels are involved with the ejection fraction being less than 20%, or if the left main equivalent has a very high grade block, or if there is an intractable coronary ischemia, and drug treatment, then you can always ask for revascularization post a non-cardiac surgery on a later date. This can also be done. For emergency surgeries, the risk has to be taken. So how long can you wait after revascularization procedure? The ACC and AHA recommend that if you put a bare metal stent, then for 30 days to 6 weeks. And if the patient has underwent a drug-eluting stent, then you have to wait for 6 months, preferably 1 year. If the patient has undergone balloon angioplasty, then you have to wait for 2 weeks or so for the non-cardiac surgery to be posted. And if the patient has had a recent MI episode, then it is better for 3 months before the non-cardiac surgery. So the period within 6 weeks is high risk because it takes around 6 weeks for the impacted myocardium to resume its function, and 6 weeks to 3 months is intermediate risk. And this period is extended beyond 3 months if there are more complications like arrhythmias, ventricular dysfunction. It has to be continued for some other reason. PG procedure, one has to wait for 6 months to elapse before non-cardiac surgery can be done. So once the patient comes for non-cardiac surgery, and that we know that the patient is on dual antiplatelet drugs for whichever reason, he might have a graft or a stent, then how do you go about it? Aspirin generally can be continued, but this decision has to be taken based upon the bleeding. So risk of thrombosis on one hand and risk of bleeding on the other hand has to be assessed. If the risk of bleeding is more, then you can one can reduce the aspirin dose from 150 mg once daily to 75 mg once daily. If the risk of bleeding is much higher than expected, like in neurosurgery or in ocular surgery, then you can even stop aspirin for that matter. The drugs are to be 7 days before the surgery, and you can start low molecular weight heparin instead of the antiplatelet drugs, which has to be stopped 6 hours before surgery. In some cases where the bleeding risk is very high, you can stop before surgery also. So there are various drugs which are still available for therapy. Patients with grafts, stents, or prosthetic walls to be on bridging therapy because the risk of thrombosis over here is very high. So currently available drugs for bridging therapy are tirofiban, eptifibatide, and cangrelor. Infusions. operative period and can be restarted post-operatively immediately after the surgery, and they can be continued until dual antiplatelet resumed. There is a whole list of drugs which can be on, and the lower three drugs, tirofiban, eptifibatide, in this chart have been shown. You can start them pre-operatively, but you can continue them 4 hours and resume 4 hours after this. This have also been given. Regarding other drugs before surgery, the patient is already on beta blockers, then there is no harm in continuing that. In fact, beta blockers are known to improve coronary blood flow by prolonging the diastole. They improve the supply-demand ratio and also stabilize the cellular membranes. They improve oxygenation. So beta blockers, if already started, then they're very beneficial. But you need not start them 24 hours before surgery. So freshly starting beta blockers is not recommended. If the patient is already on beta blockers, then it is beneficial to continue beta blockers. Alpha agonists are better avoided. So they decrease the sympathetic outflow and the blood pressure, and they should be stopped. Statins having effects, they also stabilize the coronary plaque. So if the patient is already on statins, then it is a good idea to continue them in the perioperative. So this is a chart which is showing how to go about a patient who is hosted for non-cardiac surgery. If the patient needs emergency non-cardiac surgery, there is no other choice. You just have to proceed for surgery with the risk assessment and risk consent. If the patient needs elective non-cardiac surgery and he exhibits acute coronary syndrome, then you have to do acute coronary syndrome evaluation. And because it is elective, you can proceed for a proper evaluation. If there is no evidence of an ongoing acute coronary, then you have to assess the perioperative risk for MACE, and then proceed for if it is less than 1%. If risk is perioperative risk is more than 1%, then you need to do the functional capacity by either a treadmill test if the patient is mobile or by a pharmacological testing or any other drug, dipyridine drug. And you can consider non-invasive testing if results are going to change the management, and then go for a non-cardiac surgery. If the results are not going to change the management, then take the risk and go for surgery if the functional capacity is poor. And if the functional capacity is moderate to good, then there is no harm in for surgery with risk, with low risk, low to moderate risk. Interruptive management would involve this balance, which I've already explained. So anything which stimulates the sympathetic system also reduce the diastolic time and rate. So anything which reduces the supply and increases the demand, which reduces the coronary artery patency or causes a difference in reduces the diastolic time or reduces the oxygen extraction by reduction in hemoglobin, for instance, or hypoxia. All these would reduce the supply, and anything which would increase the demand by increasing load or afterload, like high BP or tachycardia, increase the demand of the. These are harmful in the intraoperative period. So the physiological goals are to maintain a low normal heart rate on both the sides. This would serve both purposes. It would increase the it would maintain the oxygen supply and the myocardial oxygen demand. So a low to normal heart rate is mandatory. You need to maintain a high oxygen content of blood with normoxia, not hypoxia, neither hypoxia nor hyperoxia, because it has been seen that if the patient is subjected to high flows of oxygen intraoperatively, then the damage is much more than that would be when the patient has hypoxia. So normoxia is the norm. High normal aortic pressure should not be there, and it should be maintained. So no hypotension, but no hypertension as well. Should not reduce coronary vascular resistance, and the left ventricular end pressure should be kept low. Then any events of hypertension or increased afterload or excessive fluid administration should be avoided. So whether to give J or regional, it again depends upon the type of non-cardiac surgery. So if the risk of bleeding is much high and dual antiplatelet drugs are used for some time, was there and the INR is still maybe 1.5 or so, then you can still go for general anesthesia, depending upon the non-cardiac surgery and depending upon the risk of thrombosis. What's the risk of bleeding? One has to decide whether general anesthesia or regional anesthesia has to be given. But the perioperative goals are the same. You have to maintain the oxygen supply and demand balance in both the cases. So even if you go for regional anesthesia, one has to be very vigilant regarding hypotension or bradycardia or tachycardia because of vasodilation and blood loss. And so these things have to be maintained in both the scenarios. So JA versus regional depends upon the type of surgery. Pre-medication is recommended because that will reduce the stress and that will reduce any event of tachycardia. Induction agent, you have to choose that induction agent which will cause minimal myocardial depression. Generally, etomidate serves this, but a good dose of fentanyl and small dose of any other induction agent can also be used in places where etomidate is not available. So anything which does not cause sudden myocardial depression and hypotension or tachycardia is recommended. Normocapnia is to be maintained. An ETCO2 of around 28 to 32 has to be maintained intraoperatively. Response has to be reduced. It mandatory that we use some agent to reduce the intubation response, because that is one area where there is the stimulation tachycardia and that would lead to an imbalance in the myocardial oxygen supply and demand. Versus TIVA, this choice is again dependent of surgery. Generally, a combination of volatile agents and TIVA can be used, and it is used effectively. Regarding isoflurane and coronary steal syndrome, generally we never go above a MAC of 1.2 in most of the cases, and in fact in some studies it has been recommended that isoflurane reducing the myocardial stimulation or stabilizing the myocardium does benefit than coronary steel. So only in very high doses of about more than 2 MAC or so, there are chances of coronary steel, and so if isoprene intensity is used, a combination of volatile agent and TIVA is generally very effective. Smooth extubation, so that sympathetic response is monitoring. Mandatory monitoring includes pulse oximetry, capnography, urine output temperature, and non-invasive blood pressure. You must use a ECG, a continuous ECG monitoring with all the 5 leads. Optional is invasive arterial pressure if the procedure is very small. It's just a hernia surgery. Then the choice remains with the anesthetist whether to put an invasive arterial line or not. But in our institute, it is recommended for all IHT patients who come for even the smallest surgery, preoperative arterial line in local. CVP and other monitoring like transesophageal echo or pulmonary artery catheter options. Mandatory monitoring includes pulse ox capno and the I have mentioned in the slide. So one has to have a very high index of suspicion for any or any change in ECG, any change in hemodynamics. One has to be very careful. You have to be prepared with all the vasoactive drugs and electrolytes. Paid the transfusion trigger in generally trigger is a little on the higher side. So surgery where there is no IHT, if you can wait for the to be given at around 8 grams per deciliter, at say 8.5 or 9, you have to start blood. Again, you have to maintain the oxygen, the balance between the myocardial oxygen supply and demand. So the transfusion trigger is a little side in underlying ischemic heart disease. Thank you.
Thank you, Dr. Abhiruchi. It was an elaborative presentation. Now I request the audience to type their questions for both the sessions in the chat box, either in the YouTube or in the DocViz app.
Yeah, Dr. Ramakrishna, did you receive any chat